Hello, my name's Sue Eardley. I'm the head of invited reviews at the RCPCH. You haven't got my biography in there. It's not because I'm trying to keep it secret, but out there just wasn't supposed to get it in. My background is originally engineering. Why not? Then I worked in a local trust in Croydon for about 13 years in various board roles, part-time, and then I went to the Healthcare Commission, then CQC looking after maternity and children's inspections, and then came to the RCPCH about 6 years ago. So I've been kind of knocking around health for a while, and about 5 years ago we set up in the RCPCH the Invited Reviews programme, which I think we've done about 75 reviews of services, networks, individuals, community, neonatal, acute reconfiguration. So we've got quite a bit of background in doctors working with doctors, nurses with nurses, clinicians together, and management, just to kind of bring into this programme. So I just want to talk fairly quickly today. I've got Kasia here with me. We've got a team of three of us together. Just talk about the programme that is hopefully coming next year, or this year, coming from April, and going forward to kind of fill in the gaps where some of the other programmes leave some questions. So the National Children and Young People with Diabetes Quality Programme, it's a sort of three-phase programme. It's got self-assessment, all units annually, improving on what's happened before. You've done self-assessment previously. We've learnt from that, and we've got a system now which will be much, much easier for you to fill in. External verification of the self-assessment, so making sure that the information that you've put in is validated, it provides a national picture, you can benchmark against it, and you can trust the data. And then peer review on a 3-year cycle, which is looking across between organisations, bringing in clinicians and experts to work with you, alongside you, to look at areas where you may need to improve, areas where you've got blocks, areas where it could be helpful. And the peer review is absolutely peer review, it's not inspection. We're really keen to emphasise that it's not CQC coming in making it difficult for you. It's people working alongside and sharing how you can make things better. Okay, alongside those three bits, there's a quality improvement collaborative, which we're piloting at the moment, and Kasia will talk about shortly, which will then take 10 to 12 units annually and provide intensive QI for them. So that's the whole quality programme together. I'm just going through a little bit of the background and what we're taking forward. And I'm happy to take questions later on in the day. Appreciate we're a bit short on time. So the aims of the programme, primarily, as we're all here, is about supporting improvement in the care, experience and outcomes for children and young people and their families. That's absolutely why we're all here, and it's a mechanism to help you to do that. So the aim is to inspire teams and networks to work efficiently and effectively to reduce that variation in outcome, because we know from the NPDA and from other data that outcome does vary around the country. All sorts of reasons, some of the reasons we know, some of the reasons we don't know, and this will enable people to get alongside each other and find out what's holding you back, find out what's influencing the outcomes. Benchmarking compliance against standards, best practice tariff criteria, fostering peer challenge, and identifying really good notable practice. What's happening that's really good? What have you discovered that you think, well, we're just doing it this way, but nobody else is doing it? So how can we share that information between us all? So you've seen the slide before, you've seen it with a black background, we've now got it with a blue background. It's Justin's slide, which you've now, earlier on, seen the extension to this. But this is really quite exciting to see where things are going. It's now gone a little bit alongside afterwards. But this is all the things that have happened so far towards bringing down the HbA1c level. So what we want to do next is take it to the next level, take it down further. Okay, so looking at that, that's the QI and QA consolidation, which is just starting to come in now and what we're talking about this morning. So the scheme integrates, we're quite proud of these pictures, so I have to put them in. The scheme integrates fully with all the other schemes that are going on. It brings in those networks together, the 11 networks all working together, so the one scheme across them all, but sort of locally delivered and supported, so that you can work with your peers in the networks, but also compare across the country, across England and Wales. So everybody will get the same programme. And the two yellow bits of the jigsaw, we're quite proud of this one, is how we're going to pull together all the data from best practice tariff, the NPDA, network managers support, spotlight audits that Holly talked about, NICE, the PREMS, the CSQM, all of those elements will come together into the QI and self-assessment peer review programme. Okay, Best practice tariff, you're all familiar with that. Almost every unit in England is funded by best practice tariff, and the best practice tariff has that series of measures which say, you need to do these to comply and to get the tariff. So we're looking at that, and we're saying the next best practice tariff coming in is going to require this programme. It's going to require a quality programme to drive down that variation in outcomes. And so when we look at costing this programme and what we can offer, we're looking at 1% of tariff to provide all of these elements of the programme. So that's what the cost of the programme will be, looking at it over 3 years. Okay, so that's coming in, and the programme coming in 2019 is going to require participation in the nationally agreed quality programme. Okay, so that's why we're bringing it to your attention now, so that we can start to get ready for that, so that you can smoothly go across to the new measures on the BPT. Justin's talked a bit about the clinical service quality measures. Again, those are coming in next year. They've been sort of piloted this year. You had your scores back, and it brought together those different processes to provide a public indicator for how your service is doing. So obviously the self-assessment can feed into that. Last year when you did the self-assessment, it was difficult to get that data absolutely consistent across the country. So that's why we've been looking at the scores. But for next year, if we've got good self-assessment scores that are validated, that can feed into that CSQM. So it links in with the completion of the care processes, mean HbA1c, the self-assessment score, and the PREM. So you've got a nice picture around the country of how your organisation is doing. Okay, Lena's just spoken about the international evidence of impact and what's happened in Sweden, and this graph that starts to bring the HbA1c levels down in Sweden as it comes down on that graph. And looking at the point on the graph where it kind of hits a sort of plateau is where in Sweden they started the QI2 programmes one after the other. And I've put alongside that, as you've probably seen, this is where England sits and Wales sit. Our levels are much higher. On the same, the denominator at the bottom is the dates, and it starts at 2011, goes along to 2015. We haven't got, obviously, Justin's new data yet because I did the slides yesterday and haven't got it. So you can see how our levels are coming down, like they did in Sweden, 12, 15 years ago. And that's the point where we think, okay, we need to think about starting how we're going to continue downwards rather than having that plateau that happened in Sweden. That's why I'm going to pass over to Kasia to talk about the QI programme.
Thank you, Sue. So just to introduce myself to everybody who doesn't know me, my name is Kasia Muszynska, and I'm the Quality Improvement Manager at RCPCH. And I'm here today to tell you a bit about the QI collaborative that we've launched in the UK as a pilot. And also we have here one of the participants of the collaborative who will also share with you a bit of first-hand experience. I usually start this presentation by talking about what Sweden did and how we were inspired by it. But since we just had the great privilege to hear from Lena directly, there isn't really that much to say. So just to capture some of the key points, the key points from the overview of the Swedish collaborative projects. So we know that in Sweden, the program engaged with most of the diabetes centers. We know that they all work towards a shared target of lower HbA1c, but driving towards it through localized projects. And we know that they had a series of learning events plus follow-up meetings and an extra support for the teams in the form of coaches who received some additional training and communication from the central delivery team. So these were the principles that we decided to also employ in the pilot that we're delivering right now. That pilot started in November 2017. And mirroring a lot of the learning that we took from the Swedish team, we recruited 10 units to work with us over a period of November through to July in a series of 3 learning events and 1 follow-up meeting, We also ask the teams to recruit champions, 1 or 2 champions to stand in for each other per team. And we've been engaging them in some additional training plus web meetings in between learning events. We've also created an online platform that they can use to share data and learning between each other. And we're going to be celebrating learning in the final follow-up meeting that will take place in July. So we have a fantastic trainer working with us, Dr. Trisha Woodhead, who's a consultant pediatric radiologist with very extensive experience in both teaching quality improvement, but also setting up and running QI collaboratives and networks. In preparation for this collaborative, we ran a recruitment over the summer period where we put out an application form with some entry criteria out to teams, and this is the final list of the teams that we have in place. I think a couple of words about the recruitment process. So some of the criteria was exactly what Lena talked about. So we asked the teams to commit all of its members to the program. So everybody had to be involved, not just a select group. We also asked that the teams secure support from senior management and that it's verified by their signature and their declaration of support in the application form. We also asked for a nominated champion to be stated in the application. And we also asked that the teams commit to partly self-fund their participation in the form of travel and accommodation. Then, once we received the applications meeting all these criteria, we also looked at ensuring that we have a more or less equal spread of units across England. So we had our first training event in November. I've included a couple of photos here. Unfortunately, photos of training events rarely reflect the energy, enthusiasm, and level of attention that were present in the room, but let me tell you, they were high. And we had a really fantastic weekend where Trisha led us through a mix of theory and practice with the key focus on 2 things. One, the improvement methods, particularly around using data, especially NPDA, and process mapping. And also, and this again goes back to what Lena was talking about, the second focal point was creating high-functioning teams. So giving teams the tools to run more structured, efficient team meetings and also to improve their teamwork skills. And since then, we know that all the teams have been working very hard. We communicate with them, as I mentioned before, through the champions and through our monthly web meetings. And each time we have a web meeting, each champion gives us a summary report of what the team has been up to. And so we know that all the teams have really taken on board the points about high-functioning teams and teamwork. They all meet regularly, or if for whatever reason they can't, they've introduced some novel solutions to ensure that they keep in touch. For example, WhatsApp groups, or having a wall in a meeting room where they share information about what they've been up to, so that whoever can't come to the meeting can always have a look at it. We also know that they've already been running their first PDSA cycles with various projects focused on things such as improving self-care, patient education, improving clinic attendance, but all of them have a strong emphasis on engaging patients and families in the design and the delivery, which is fantastic. We also built, as I mentioned before, a platform for them called QI-IQ, which is a closed access working space where they've been able to, on the one hand, download all the materials that Tricia shares with them to support their learning and their progress. And on the other hand, they can also upload the documents that they've created with their teams to that space for others to see. I will now hand over to Phoebe. Phoebe is from the Hillingdon Hospital, one of the teams participating in the collaborative, and she will tell you a bit more about what it's like.
Hi, everybody. Thank you for giving me the opportunity to share what our team at the Hillingdon Hospital in West London has been doing with the QI Collaborative. Quite nervous as well. So my name is Phoebe. I'm one of the paediatric diabetes nurses. When we heard about the QI Collaborative, we were really keen to participate. So why we wanted to take part, even though we had been steadily improving our patient outcomes, we wanted to accelerate that improvement. The QI provided us an opportunity to learn and understand a model that has significantly improved patient outcomes in Sweden. We also wanted to learn from and work with other teams from around the country. What we have done so far, so we attended the initial weekend event. From this, we decided our QI project. We decided to focus on our insulin pump patients with the aim to bring their HbA1c down. We have used techniques and strategies we have learned from this weekend event to run weekly meetings for this project, such as PDSA cycles, and making better use of data available to us. We have already implemented a few service changes since attending the event in November, such as pump policy and revamped our pump refreshers. And that's the journey so far.
Thank you. So before I hand over to Sue, just to say that we have another event coming up in February, the second event, where we're going to continue working with the teams and enable them to share their learning and improvements between each other, and learn more about the improvement methods and measuring success. But as Sue mentioned, once this program kicks in, we're planning to do more iterations of this pilot project. So we're very much hoping that some of you or all of you will want to participate in the future. Thank you.
Thank you. It's just so exciting to hear the teleconferences when the champions ring in and say the stuff they're doing. And what it's doing, it's tapping into the energy that people have that isn't being tapped into in their normal day-to-day work because it's too busy, there's not enough time, you haven't really got the energy. So one person going on a QI course comes back to the team, really difficult then to take it forward. But if the whole team's been on it, there's no hiding place. You have to absolutely move forward. And you can convince your board, you can convince people that this is really going somewhere. And it's the energy that we picked up from the teleconferences and from the weekend that really, you can't put a price on. It's just fantastic. And we really want to share that out more widely so that everybody can have an opportunity for that. Anyway, enough of that. Back to the other part of the programme, which is the self-assessment. Very aware that you've had 2 rounds of self-assessment and 1 of sort of full peer review in the past. And that some of that has been quite arduous, quite burdensome in terms of perhaps uploading lots of information, in terms of evidencing the questions, and in terms of the scoring the questions, because there was quite a lot of questions to fill in, quite a lot of detail, and then you had to put all the evidence in. And that's quite arduous, quite a lot to do when you've got a busy clinics and not enough people about. So in the summer, we wrote round to everybody and said, well, if we put this programme in, how did you find self-assessment helpful before? How did you find peer review? What do you want from this future programme? And we had fantastic replies back. We had 108 replies out of 155 MDTs with really useful information that we fed into designing of the programme. And just one of the slides from the whole report on that is we said, well, was the previous self-assessment process helpful? And how was it helpful? And I've got down here, you can't see the detail, but it says supporting service planning, raising the profile of the service in the trust, identifying risks, securing external funding, supporting business cases. So you have the evidence from that you can then use in all these other ways to make your service a priority in your trust. And out of that, as 15% of the replies said none of these or no experience of doing it. So very, very few people actually found that self-assessment wasn't valuable in some way or another. So it's easy to hold that thought, because the way we'll design it, you'll be able to use it in many, many more ways. So this is quite a busy slide again. I just wanted to run through with you our thinking as we're designing this. So we went out to consultation in July on the measures, pretty much the same measures as previously, but a bit more granular. So you've got individual measures now. Instead of having previously 27 measures, you've now got 90 elements with those for MDTs. That sounds like an awful lot more work, but it's actually less work because it's just yes, no. So you can go through it and you will know yes, no to each of those questions. And in terms of scoring, it's much easier because you either have or you haven't. And so it'll be much, much clearer in terms of your score. So that's how we've designed it, and the measures actually went out in November, so you should have seen those. If not, they're on the website. So you know what you'll be looking at in terms of self-assessment. In terms of how we do the external verification, we're not going to look at every bit of evidence from every organisation because that's not cost-effective for anybody, and it just takes up too much time to do. We've got to trust you that you know what you're doing in terms of reporting on the self-assessment. But it's also important to have some kind of verification to make sure that actually it's all pitched about right. So we've come up with a way of verifying that I've tested out on a few people when I've spoken to networks, and I haven't had much feedback that there's a problem with it. So if there is, please let me know, because this is how we're planning to do it. So once we've scored everybody, you've put your scores in, be about the end of May, we'll say, okay, the 4 units with the highest scores and the 4 units with the lowest scores, we perhaps need to have a look at them to make sure there's not a misunderstanding gone on, and see kind of what's happening there. So those 8. And then looking at the last external verification where you had scores on sort of much bigger basis, we'll look at anybody who's changed significantly, because again, there might be a misunderstanding, or there might be something that's either fantastic that's changed or something which you need help on. And then we'll take 10 other units just selected at random. So altogether we'll look at about 20 out of 155 MDTs. And for those 20, we'll say, okay, let's have a detailed look at your evidence. So you kind of need to have the evidence there, but you won't all have to upload everything, because that way we can then make a judgment on whether actually it looks like it's about right. So if there's somebody who's completely misunderstood, if we get feedback during the process that there's not enough explanation, we can clarify that as we go through. So hopefully all the things that came out as a problem previously we've addressed. But I need to know if there's anything else that we haven't addressed yet. Okay, so those final scores will then feed into the CSQM, because they'll be validated scores that you can be proud of. Okay? So, very quick canter through the peer review programme. You know how it works. You know what's happened before. It's building on that, but it's building on that with the extra intelligence from the previous round, and with that real knowledge that the reviewers that we'll be using from yourselves, we're looking for people to nominate themselves. There'll be a small application form, sort of, why do you want to do it, a little bit of background, so that we can then work out who's the best people to form the review team to go and do the visits. And so that we can provide you with induction training that gives you more than just people talking at you. It gives you an opportunity to practice some of the techniques, to learn about interviewing, to sort of develop your general skills in terms of peer reviewing, not just for this programme. And they'll get you CPD points and everything as well. So that's going to be within there. So the programme is the self-assessment, sign-off. We'll do a baseline analysis, as I mentioned, about the verification. And then we'll go into peer review. And we'll do a third of the units each year. So we'll work through everybody in 3 years. And if you're not being reviewed, then you'll be supplying people to go and review somewhere else. Or you'll be on the QI collaborative. So there'll be something happening all the way through. For this 3-year programme. But if we spread it out that way, it means that people can watch the improvement, they can share the learning. It's not one intensive year that's everybody in it and then it's all forgotten. It enables you to build that process of this is actually how it feels to be right. Okay? So that's what we're planning at the moment. These slides will be available. They'll be available on our website, and they can probably come around after the conference as well. So you don't feel you have to write everything down just now. In terms of timeline, we're looking to the end of January to sort of develop the programme. We're working with the National Children and Young People Diabetes Network, listening to you, really hearing what you want and what would be helpful for you. We're testing the process. I've just talked through that. We're refining the business case. We're going to help you to be able to make the case in your units for why this needs to be funded and supported. And then moving on to March, we'll be stepping up our staffing to prepare for it. We'll be getting the processes ready. We'll be piloting the self-assessment to make sure that the web platform is absolutely robust. We've been trying to break it. We're not able to break it because it seems to be working quite well. It's built on the same web platform as the NPDA, so it's the same guys behind it who understand how it works, and it's quite intuitive. And we'll be preparing people for rollout. And then following April, if the funding's secure, we'll then run it for the first year. We're looking at the self-assessment in April, May, and we're looking at the first visits, peer review visits in June, July. We were going to have some in September, October, but I found out last week that, of course, September is manic for you all because you're in schools. So we'll obviously adapt it because there's no point in trying to run the programme when you're just too busy to take part. So we're going to tweak the whole programme against, what would be most useful for yourselves, both in reviewing other units and having the visits come through. And we just need to keep these conversations going. Okay, and there's just contact details for me and for the programme. We've got the web page, we've got email address, and we've got phone number. So please keep talking to us. Okay, how are we doing time?